hungry for lunch, but we'll go through the basics and the advances of blepharoplasty so that at the end of the session, at least you're confident enough to start this procedure. If you're already doing functional eyelid surgeries, add this to your repertoire and try and introduce some aesthetic procedures.
हाँ जी, हाँ जी. Good afternoon, everyone. I welcome you all for this instruction course, which is a step-by-step demonstration regarding the cosmetic upper and lower eyelid blepharoplasty and eyelid contouring. The following talks will be covered: aesthetic assessment of the face by Dr. Vatsalya Venkatraman, who is an ex-fellow of Sri Shankardeva Netralaya, Guwahati, under Dr. Kasturi Bhattacharjee. She is a consultant at present at the ASG Eye Hospitals, Jodhpur. Upper eyelid blepharoplasty step-by-step approach will be covered by me. I am a fellow at Sri Shankardeva Netralaya, Guwahati. Lower eyelid blepharoplasty, the transcutaneous approach, will be covered by Dr. Aditi Mehta Grewal, who has done a double fellowship from PGI Chandigarh and Sri Shankardeva Netralaya, and currently is having a private practice in Chandigarh itself. Lower eyelid blepharoplasty transconjunctival approach by none other than Dr. Kasturi Bhattacharjee ma'am, who needs no introduction. Who better than ma'am to guide us regarding this topic? She is the head of department of the oculoplasty, oculofacial aesthetics and cataract and refractive services at Sri Shankardeva Netralaya, Guwahati, and an inspiring mentor to all of us. How to tackle the brow, which will be again presented by Dr. KB madam. Blade-free blepharoplasty by Dr. Debraj Shom, who unfortunately couldn't join us here today due to overlapping sessions. He is an ex-LVPI fellow with a thriving aesthetic practice in Mumbai called the Aesthetics Clinic, and has more than enough experience with blepharoplasties and other aesthetic procedures. He'll be joining us virtually.
Assessment of the face, what to look for when you have a patient who may be a good candidate for some periocular aesthetic procedure like blepharoplasty.
Can we lower the background score a little bit? Actually, that's not possible. All right. Okay. Outside. Good afternoon, everyone. So, actually, Team KB has taken up the mammoth task of keeping you hooked during the lunch session. So, it's going to be a challenge on our part. Hope we can deliver some interesting points. So I'll be covering aesthetic assessment of the face. So what are the basic steps involved is, there is patient history and systemic evaluation, expectations and goals that the aesthetic physician must discuss with the patients, photographic documentation preferably done in the natural head position, a psychological assessment which must be thorough from the end, from our end, a basic ophthalmic examination and detailed facial examination, which is called the facial analysis, which can be broken into three segments: the orbitocelaton and globe, forehead and upper eyelid complex, lower eyelid and mid-face complex. So the aesthetic physician must have an educated eye, and the face must always be analyzed both as a single unit as well as in components. The periorbital region is a key defining feature of our face, because eye contact naturally draws attention towards this zone. So what are the broad pathologies that you need to rule out when it comes to patient history? Thyroid eye disease, the recommended disease quiescence period of at least 6 to 9 months prior to rehabilitative procedures. Myasthenia gravis. You need to establish the systemic status of the patient, which is conducive for surgical candidacy. If the patient is on any pre-existing medications, any prior refractive procedures, and any prior aesthetic surgical or non-surgical procedures that the patient has undertaken. Within ophthalmic examination, we have visual acuity, ocular movements, dry eye syndrome, and tear drainage system malfunctions, if any. So coming to the orbitoskeleton and globe, the facial bones are basically forming the framework and the source of attachments for ligaments and muscles that define the face. The chief bones amongst them are the zygoma laterally and the maxilla medially. A prominent malar eminence is considered youthful. Aging is associated with the resorption of intraorbital rim leading to malar hypoplasia. So what you can see in this young individual is the vector that you can see green in color and the vector over here that you can see red in color. So essentially if you drop a line from the supraorbital rim to the infraorbital rim, it's considered to be positive if your cornea is lying posterior to this line, and that marks the sign of youthfulness, whereas with age the vector turns negative when the cornea lies anterior to this line due to the resorption of the infraorbital rim. Now the two things that you need to pre-aesthetic treatment evaluation is the exophthalmos, which needs to be ruled out even as a part of the thyroid eye disease or due to any previous aesthetic procedures that patient has undergone, and enophthalmos, specifically superior sulcus hollowing, which is a sign of tired or aged look. Now we can measure the anterior globe prominence using the Hertel's exophthalmometer. How does this factor in the surgical planning is that in patients of exophthalmos, the position of the lateral canthal fixation in case of lower eyelid blepharoplasty possibly requires a higher placement and needs to be tailored according to the degree of the prominence. The second is the forehead and the upper eyelid complex. These are the various components of the forehead, the brow fat span. Tarsal plates show when visible is considered to be a sign of youthful face. The lacrimal gland, the margin reflex distance 1 and 2 that plays a role when you are evaluating for any pre-existing ptosis. Canthal angles, lacrimal drainage system, lower eyelid height and inferior orbital rim and retaining ligament. So the parameters can be broken down into skin, rhytids, brows and eyelid. In case of male pattern baldness wherein there is a receding hairline, these kind of patients, if they are undergoing any kind of surgical treatment, can benefit from pretracheal incisions. So male versus female brow position, the normal male brow lies along the superior orbital rim and is relatively fat, whereas the female one lies slightly above the supraorbital rim, the highest point being located laterally, could be either at the level of the lateral limbus. And why is this important is because if any kind of aesthetic treatment the patient is undergoing any evaluation, we must try to restore the normalcy and not give a relatively surprised look. Brow symmetry, any pre-existing asymmetry should be noted so that post procedure there is no dissimilarities between the patient expectation and the physician's outcome. Brow ptosis. So with the downward gravitational pull as well as the soft tissue laxity that factors in with age, we can see brow ptosis, and that can be seen as flattening and the loss of definition. One can also see in case of brow ptosis there will be a prominent frontalis overaction which leads to horizontal forehead furrows. So coming to rhytids, rhytids could be static or dynamic. The dynamic rhytids normally benefit from muscle denervation procedures like botulinum toxin. The frontalis gives us the horizontal forehead rhytids. The glabular lines, which are vertical 11 in shape, are because of the corrugator supercilii. The orbicularis gives us lateral crow's feet. Bunny lines across the nasal dorsum are because of the procerus. And there are the other lower face lines, which are the nasolabial lines, the perioral marionette lines. So how do you elicit this? You'll have to elicit the patient to perform various facial expressions. Patient will have to raise the eyebrows, grimace, smile. So all the facial muscles, their actions need to be elicited and pre-recorded before any procedure. Upper eyelids, droopy, wrinkled or tired. So dermatochalasis needs to be evaluated beforehand. It could be primary because of the true age-related excess of eyelid skin. It could be secondary due to excess skin because of the sagging of the brows. So like I told beforehand, brow ptosis needs to be evaluated carefully, because in case of brow ptosis with patient who are having dermatochalasis, you can end up causing excessive excision of eyelid skin during blepharoplasty. With age, there is loss of integrity of the orbital septum in the upper lid, which can cause prominent eyebrow fat pads and displacement of the orbital portion of the lacrimal gland that can also increase the bulk of the upper eyelid in addition to dermatochalasis. Blepharoptosis, we must evaluate any pre-existing ptosis in the primary gaze with frontalis relaxed and brow fixed in its natural position. This will definitely alter surgical planning of blepharoplasty. What you can see in this picture is an asymmetric lid crease that also needs to be carefully looked for, because in case of an asymmetric lid crease wherein it's upshifted, it could mark levator dehiscence. So in these patients with levator dehiscence and coexisting dermatochalasis, in addition to blepharoplasty, you may have to perform an LPS reinsertion. Lower eyelid complex and midface. So essentially there are three components that take place. There is orbicularis atrophy, there is weakening or laxity of the supporting ligaments, and there is aging of the weakening of the lower orbital septum that causes the orbital fat pads to prolapse. As you can see, the herniation of the orbital fat pad. So normally the lower eyelid is in continuum with the cheek, but due to age-related changes which occur in the mid-face, you can see that there is a convex, concave and convex pattern, which is a classic sign of the mid-facial aging and causing a prominent nasojugal on the medial side and a palpebromalar fold on the lateral side. Volume depletion and weakened midfacial soft tissue support causes the loss of lid-cheek junction contour irregularities. Lastly, eyelid laxity that can be evaluated with canthal laxity. You need to perform the pinch test and the snapback test, and that is the last but not the least in the evaluation of the aesthetic patient. To sum up, critical aesthetic assessment of the periorbital face includes knowledge of periocular and ophthalmic anatomy, understanding the morphological changes associated with age, sex and race, considering the orbital skeleton and globe, forehead and upper eyelid complex and lower lid and mid-face complex. Aesthetically pleasing and functionally sound interventions can be performed only when there is a holistic assessment. Lastly, we should have a smooth dialogue and patient communication. Thank you.
Thank you, Dr. Vatsalya. Indeed, aesthetic assessment is the first step. In all these procedures, not just aesthetic but even functional blepharoplasty, eyelid procedures, the counseling and the chair time are very important. Because when a patient comes to an eye hospital, conventionally they think it's a cataract surgery. They come in and they go out and it's barely visible. Now with topical and laser surgeries, there's no redness in the eyes also. But here we are doing plastic surgery in a very delicate area, and if we are going with our blade unprepared, that's not enough. We need to know each and every detail, because no two cases will be similar, to the extent no right eye lower lid will be the same as a left eye lower lid. So assessment is very important. We are changing the sequence slightly because ma'am has other commitments. So we'll have Dr. Kasturi speak on first the lower lid blepharoplasty, the transconjunctival scarless approach, followed by the eyebrow region, how to tackle that.
Yeah, so I'll be covering two topics. At the outset, I would like to thank Dr. Aditi for having me in this course. It's so nice to see them growing, and today they have become one of the biggest, highest number of doing plastic surgery, not only in their places but also outside the states. Dr. Aditi practices in North India, like she had done her MD from All India Institute of Medical Science, then her senior residency in PGI Chandigarh, then a fellowship at Shankara Dev Netralaya. And it's so amazing to see the number of surgery, both aesthetic and function, that she is catering to all the people in the Northeast. And Vatsalya, the previous speaker, like she is a wonderful surgeon. And I was so happy to see that she's not only working in Rajasthan, she is going, I think she'll be very soon coming to Guwahati also, because she's going to all the states. She's being invited to all the states to perform the different plastic surgery. So what I want to say that even when we started a career, we started by attending the different conferences, and every conference you take, you learn something, and it's very essential that you really consider yourself to the student, and you have to learn it and go back and practice, because you have to learn from your own experience, learn from your own mistakes, or you see what people talk about their mistake. But it is not just saying and not doing, you have to start it, then once you start, there is no stoppage to it. So yesterday there were doctors asking me that how do we do upper lid blepharoplasty or the lower lid blepharoplasty. I'm supposed to cover only on transconjunctival, but as Dr. Shubhra is not here, so briefly I will also cover some of the aspects of the eyebrow lift. So, no financial interest. So when we talk about the fat, because when we talk about blepharoplasty, it is basically we are dealing with the fat. And when we look at the fat, the upper lid basically has got 2 prominent fat pads and the lower lid has got 3 fat pads. And the most important structure between the 3 fat pads, that is the medial and the central fat pad with the inferior oblique muscle. So if you look to this animation here, the upper lid fats are much superficial. But when you look to the lower lid fat pads, it has a 3-dimensional structure where the central fat pad is very superficial, the medial is deep and the lateral is the deepest. So it falls into a 3-dimensional structure. So Dr. Vatsala has mentioned very well about the negative vector, positive vector, about the indication of the upper lid bleph and the lower lid bleph. What I want to mention that in all cases of fat prolapsing, we do not go for surgery. If you have a very small amount of medial fat pad prolapsing, you can also conceal the fat by use of different types of filler. Injection dermal filler, there is a hyaluronic acid filler or other types of fat filler, anything you can do. But if you have something like a double convex deformity like this, and this double convex deformity is characterized by the prominence of the orbital rim, it is characterized by the lengthening of the lower lid surface area and the bowing of the orbital fat. And when you see that this orbital fat has prolapsed to such an extent, it is much anterior to the plane of the anterior lacrimal crest and with too much of lengthening of the lid, these are the situations you have to go for the lower lid blepharoplasty. And secondly, how do you assess or how do you determine what type of blepharoplasty, whether you'll just excise the fat or you'll keep the fat and as a tissue preserving philosophy. So there's a very nice paper I'll be showing you. But what we do with the fat, we use the fat as a filler. This fat will be used as a filler and this will be transposed into the anterior part of the maxilla down below the soap to as much as below, so that it will give a very good effacement of the lid cheek junction. Because as we age, you see there's a very prominence of the orbital rim. So it gives a double convex deformity. So you need to fill in this prominent area so that it gives a very nice effacement. So this is what we call a tissue preserving philosophy to address the undesirable progression of the aging eyelids. So this is a very nice paper. I think this is available online. You can read this paper where they have shown that in what type of surgical planning we do as per the lengthening of the lid or as per the prolapse of the orbital fat. If the lid is lengthening is very less, like in young people will find a very less amount of lid lengthening. These are the situation you can go for very customized excision of the fat, and which is a very simple surgery where you need to expose the fat. Do not pull the fat, whatever is possible, whatever comes out by itself, just excise it. But if you feel that it is a little more, which less than 19 millimeter or less than 2 centimeter, these are the situation you have to take your decision. Whether you will just cut the fat excision and later do an augmentation with dermal filler or the fat filler, or whether you like to go for a fat transposition where on the table you use the patient's fat as an autologous filler. And if it is more than 19, definitely you would like to go for a use of autologous filler. So this is a nice paper, and why we have all these changes, I think Vatsala has mentioned very well, because of the soft tissue changes that we have, and these are some of the soft tissue changes, and also the bony resorption. And this she has shown very nicely what is positive and what is a negative vector. That means when we are young, so this we need a high cheekbones. They say no, high cheekbones is the beauty of every female. So when we are young, this cheek is so prominent. We have a very nice maxilla, very nice zygomatic arch. So what happens? This malar eminence is much anterior to the corneal plane. So what happens when we grow age? Besides the soft tissue changes, it is a bony changes which occurs more. So what happens? This malar eminence, it goes behind the plane of the cornea. So this is what we call the negative and a positive vector. And there are multiple papers related to it. You can go through this, what is negative and the positive vector. So I'm showing a small video how we do a lower lid blepharoplasty. Always for the ophthalmologist, it is not that it will be done only by the oculoplasty surgeon. It can be done by anyone, provided you know the anatomy. So it should be done by a transconjunctival approach, because if you do a transcutaneous approach, there is chance that there may be some scarring, there may be a lid retraction. So for the beginner, a transconjunctival approach is much easier. So if you just start it, then do a canthotomy cantholisis, you'll get a more bigger space to work in. But if you are like, you feel that you have done a good amount, then you can go do without doing a canthotomy cantholisis, directly expose the conjunctiva, give an incision, then you make the small incision on the orbital septum. So once you make this incision on the orbital septum, you can push the globe down and you can see the fat is prolapsing out, and it is very easy to take out the fat if you are in the correct plane. This is the inferior oblique muscle that you see here. Try to separate all the adhesion. If you don't separate the adhesion, there is chances that post-operatively there will be adhesion that might lead to diplopia. So these are the beautiful fat pads, these are pedicles that are being created, and now what you do, you need to transpose it. How do you transpose it? Because we have a very important ligament which is an osteocutaneous ligament coming from the bone to the skin, and this is known as an orbitomalar ligament which lies in the inferior orbital rim. So you have to release the ligament that you can see here, and once you release the ligament, it becomes very easy to transpose this orbital fat down above the soup as down as possible. Is it clear for you? So transconjunctival incision, expose the orbital septum, give the neck, expose the fat and fashion the fat. And better you should have a good cautery. In case you have any bleeding, just cauterize the bleeding, but do not go for excessive cautery because chance that the pedicle flap may not survive. Okay, so this is how we transpose it. You can transpose initially when you start, you transpose with only medial transposition because you have the tear trough there medially. But as you develop more experience, you can decide whether you like to transpose the medial, lateral, central, all the 3 fat pads. So once the 3 fat pads are being transposed, you can retain this suture for approximately 10 days. And after 10 days, you can remove the suture. And then you will see that prominence of the orbital rim, which we see preoperatively as an aging change, gets much reduced. Okay, so this is at the completion of the surgery. Even if you don't give conjunctival suture, it is okay, but I usually give 1, 2 or 3 conjunctival suture for a better apposition. So these are some of the patients which we have already reported. You can see this is what we call the prominence of the inferior orbital rim. This is a lengthening of the lid, and you can see that is much less post-operatively, and this is in the side view. And this is, you can see the conversion of this negative vector into a positive vector. We want the malar eminence to be much anterior. We want the beautiful high cheekbones, and which is considered today as a sign of beauty. So this is again, I am showing us a very small video just for repetition so that you remember. So what you do a transconjunctival incision, expose the 3 pedicle, and once you develop the, fashion the 3 pedicle, release the orbitomalar ligament. This is a quad blepharoplasty where we have also done the upper lid. Always do the upper lid first if the patient comes to you for the lid, because of the gravity, the blood will keep on flowing. If you do the lower lid first, it becomes difficult. So this is what, once you do the fashioning of the flap and then you transpose it and put the 3 sutures, or you can also have only a 1 flap or 2 flap as per you see how much amount of the inferior prominence of the orbital rim is being seen. So the same procedure done in the other side, and these are how the fat are, and also be very careful of the inferior oblique muscle, and this is the inferior oblique muscle, and then this are the transposition of the fat pad. Voice is totally gone because all these days since 12 onwards back-to-back session. So this is a post-operative. You can see this are some of the patient. So this is a very important point because there are always questions that how long this fat lasts. So this paper shows that it lasts for 6 to 8 months. But I have some of the patient falling almost for 7 to 10 years, and I could see the fat is there. It has not gone, provided the blood vessel in the pedicle is being well preserved at the time of the surgery. So these are some of the patient pre and post-operative following the surgical procedure, and these are also some young patient. It's not necessary that you have to transpose all the 3 fat pads. Even the transposition of 1 or 2 fat pad is sufficient to convert this negative vector into a positive vector. Okay, but sometimes what happens, you see patients like this. So these are the patient, you can say the whole mid-face has drooped. So this is a patient having a mid-face ptosis. So here you need to also do some amount of correction of the mid-face, like you need to do a mid-face lift, and this is the situation where you do a transcutaneous blepharoplasty. And this is a very important paper where they have shown that when you are in a supine position, the effect of gravity is not there. So what happens, the advantage is that the effect of gravity is not there, so you do not get the aging changes. So the concept is that you need to overcome the effect of gravity. So I'm showing a small video. I think Aditi, you're speaking on transcutaneous. I think I'll just skip this. So this is very important, that you just give the incision on the skin approach, and then it's same, expose the orbital septum, expose the fat. But when you do a transcutaneous approach, always excise the lateral fat pen. I like showing this patient because this is how she came to me and this is how she looks now. So these are some of the patients before and after the surgical procedures. These are also the quad blepharoplasty. So before I end, I would like to mention that all these procedures are basically done to address the undesirable aging changes, and there are different ways of managing. And also the most important thing, that patient, you have to explain them about the downtime, because many a times they'll come to you just before any celebration or marriage or some function, and they say that we want to look young. At least keep a downtime of approximately 6 weeks. Thank you very much for patient hearing.
Thank you, ma'am. I think you beautifully covered the transconjunctival approach as well as the pedicles. So that's something which I think ma'am is doing the maximum number of blepharoplasties in our country, and the pedicle approach is something, it's a delight to see it on the screen. It's even more delightful to see it in person, and ma'am does have a fellowship program as well as an observership program, so feel free to go and learn from her. Ma'am will also be taking up, Dr. Shubhra couldn't make it to the conference, so she was going to speak on the eyebrow, how to tackle that, and ma'am will be taking that topic for her.
So this presentation I should go slow because it's only today I realized that Shubhra is not here. So morning I made this presentation. So let me see, where is this presentation gone? Yeah. How much time do I have? I can go slow, 10 minutes? Okay. Is it coming? Can you? Yeah. So this is about the droopy hood, that is a brow ptosis, and how do we manage the brow ptosis. So no financial disclosure. When I speak about brow ptosis, I usually like to comment on this. I mean, what Dr. McCord has mentioned. He has mentioned a droopy hood to that of a curtain rod that has loosened, that had fallen, causing folding of the curtain. So that is what the aesthetic surgeon describes a droopy hood. There are numerous causes to it, and one of the most common causes is dermatochalasis, which is a aging change. So this dermatochalasis basically occurs because of the effect of gravity, number one. There's a bony resorption, there's loss of the tone of the frontalis muscle, and also there's deflation and descent of the soft tissue. So there's a very important paper which was in present when I went for the Japanese Society of Plastic and Reconstructive Surgery, where this doctor has shown so beautifully how the thickness of the upper lid skin differs. See, in the upper lid, it is near the brow, it is much thicker, and as we come towards the cilia, it is much thinner. So the gravity effect is always there, and most of the causes of aging is because of gravity. So the different causes of drooping, one is I have already mentioned age. The second being the facial asymmetry. It can be a mechanical cause, and the most common causes can be a spasm, either blepharospasm, hemifacial spasm, apraxia of lid opening, and also can be a Meek syndrome. The 7-nerve paralysis also one of the causes. Because of the 7-nerve paralysis, there is loss of tone of the frontalis muscle, there is loss of tone of the orbicularis muscle, and the senile ptosis can be one of the cause. Myasthenia itself can be one of the cause. The lacrimal gland prolapse can be one of the cause. So you need to address the situation. As per the cause, you need to give the treatment of this brow ptosis. Like this is a young girl, but still you can see everything is hooded out here. So you need to do a surgery and give a much better look, and this is how she looks after the surgical procedure. Yeah, Vatsala has already mentioned about how do we assess the eyebrow. So this is a beautiful eyebrow. Like if you draw a line vertically from the medial end of the eyebrow, it should touch the ella of the nose. And once you draw a line tangentially, then it should touch the lateral canthus and the lateral part of the eyebrow. And the highest point of the eyebrow lies at the level of the lateral limbus. So this is what we call the eyebrow symmetry. And you should know about the tarsal plate show and the brow fat span. So you should always remember that there is a difference between a male and a female eyebrow. Male eyebrows are basically heavier and they are much at a lower level. They are just at the rim. But the female eyebrows are much at a higher position and is much above the supraorbital rim. So treatment can be either non-surgical and surgical. Non-surgical, there are multiple ways, whether it can be injection botulinum toxin type A, or it can be lasers, radio frequency. People now do so much of radio frequency. People use the ultrasound, that is the HIFU, the high intense ultrasound, and also the dermal fillers. So if you see the muscles, the only elevator of the eyebrow is the frontalis. But all this muscle, whether the orbicularis, the procerus and the choroides, these are the muscle which pulls the eyebrow down. So when you do a chemodenervation, you have to target those muscles because these are the muscles which are responsible for pulling the eyebrow down. So you need to touch all these muscles, especially the central group of muscle. As you can see here. Also, you need to touch the orbicularis, which is a major muscle which pulls the eyebrow down. So this is how we draw it, and accordingly we inject the required amount of botulinum toxin. So this is how we injected at least 3 points in the orbicularis. Why we inject in the orbicularis? Because the orbicularis pulls the eyebrow down. So what is the antagonist of orbicularis? It is frontalis. So once the orbicularis becomes weakened, so the frontalis will take an upper hand and will pull the eyebrow up. Okay. So these are some of the patients before and after the dermal, injection botulinum toxin. And also sometimes we use the dermal filler. There are different ways of doing it. You can use a needle or you can use a cannula. Cannula is safe because the chance of vascular complication is much less as compared to the needle. And you need to, when you use a needle, you should hit the periosteum. Just pre-periosteal, the product should be there. Can you see I'm injecting the 3 points? I'll show you another technique, what we are doing with the cannula. And every time you inject, you have to aspirate so that you don't come up with any vascular complication. So there are different, literature says that some says you have to wait minimum for 8 seconds, but the latest literature says that they got a vascular positive aspiration after 39 seconds. But what I do, I count till 12 seconds, like 1, 2, 3, 4. If there is no positive aspiration within the 12 seconds, then I go for direct injection. So this is how we do a cannula. This lady, she is a model there in my place, and she wanted some amount of the brow lift, and she doesn't want to take any botulinum toxin. So this is how I have used a cannula to inject in the brow region, and you can see there has been deflation of the brow. She is quite young. The brow looks much deflated, and this is the best way of doing a brow, correction of the droopy hood. And this is, she is otherwise having a good brow. She wanted a little amount of lift, and this is just after the procedure where you can see a beautiful lift and also beautiful reshaping of the eyebrow just with injection dermal filler. So, and third way of giving a lift to the eyebrow is with a thread. There are different types of thread. That is the PDO thread, that is PLL thread, that is PCL thread. But what we initially used to do, we used to do a PDO thread. But what we have realized is the PDO thread lasts maximum for a year, and it is the PLL thread which lasts much more than a year. It might also last for 2 years. So this is how, like, one of the lady initially with the PDO thread, and this is also PDO thread. You just need to make an entry, and then these are all blunt tip cannula, so it is a safer way of doing. So you, and how much amount of lift you want, you just pull it, and you can see on the table you will see the lift of the eyebrow. So this is what you see. So these are the blue colors are the pedio thread, and then you can see the change in the eyebrow before and after the surgical procedures. And little bit about some of the surgical principles. The one of the very common procedure is the internal bropexy, and this is a surgery which we do it along with the blepharoplasty. So this lady, you'll see the blepharoplasty has been planned, and then you need to fix the eyebrow tissue deep down to the periosteum so that it doesn't come down. So what we are using a 5-proline. You can also use a 5-polyester, that is a polyder. Make an incision approximately on the orbital rim, which is 10 millimeter above the orbital rim, and then you fix the soft tissue and also the roof approximately 10 millimeter above the orbital rim. Why 10 millimeter? Because we know the eyebrow lies approximately, if you measure from here to here, it is approximately a centimeter for the female, especially above the eyebrow. So these are some of the patient before, and you can see this beautiful lift along with the upper lid blepharoplasty and the internal bropexy. Sometimes what I have already mentioned, then along with the orbicularis, the procerus and the corrugators also pulls the lid down. So when you have patient having both a medial and a lateral drooping, so along with doing internal bropexy, you need to remove some amount of the procerus and the corrugators. Is it clear? Because if you only lift the lateral, the medial will be still drooped, right? So you extend the incision. This is how you check for the corrugators. These are all mimetic group of muscle. That is, they originates from the bone and inserts into the skin. So they are very superficial group of muscle. You have to pull the muscle and try to exercise as much amount of possible, both the corrugator and also if possible some amount of the procerus. You can see the whole of the forehead gets pulled and since you have removed it, so what I am doing, I am trying to cover the gap which where the procerus corrugator was actually lying, and that we have filled up with a filler with a fat, so that the chance of postoperative scarring is much less. You see this looks so beautiful before and after. She also has a medial bulge out. So we have removed her corrugator, it gives a much better. Can you see the medial bulge out here? Well, let me show you. This medial bulge that is not present after the surgery. So here this is a very simple way of lifting the whole of the eyebrow. Somehow, like sometimes we do use the endoscope. I don't have that video because I was not prepared for this talk. But also without using an endoscope, you can do an endoscopic brow lift. Okay. Oh, this is again a very simple way. I think it was first described by Guy Mestri. He have shown that where a small incision you give in the lateral part of the forehead, just above the brow, try to expose the frontalis muscle. So his first technique is what? Like his frontalis muscle is, it does not inserts laterally, it is more centrally. So the same frontalis muscle, he pulls it and gives stitches to the lateral part of the eyebrow. And this is the same technique. Once you expose the frontalis, you can shorten the frontalis or you can plicate the frontalis. You can see I have resected, like how we do for the squint surgery, resected some amount of the frontalis, and now once you strengthen the frontalis, this frontalis will be lifting up the eyebrow. This is a very, I think, beautiful surgical procedure, and it really gives a very good lift. Like look at here and look at the lift here. This is like she was very conscious of this, and otherwise also she was having a very beautiful eyebrow, but she wanted a further lift, and this is how we have done with this surgical technique. Look at the beauty, like this is from here, it has been lifted up to here. So this is a very simple way of doing, and especially and also when you have a very big heavy brow, especially the males, then you can directly go. But what happens in the Indian skin, the chance of scarring and pigmentation is very high. So I do not prefer, but very rarely I do this, and that's why this is one of my very old slide. You can see this is the gene. They look totally different, right, after the blepharoplasty. Like if you look this and look this picture, he looks so much younger. So there are also different ways of managing this browtosis. Sometimes in dermatochalasis we do something which is called the extended incision or extended excision of the skin, And these are the different types of incision that can be given, and this is how what we do as an extended blepharoplasty. Just remember, for a cosmetic blepharoplasty, the incision should not touch the lateral canthus. But when you do a functional blepharoplasty, which is the extended blepharoplasty, the incision should go at the lowest point of the lateral hooding. So all this hooded area, it needs to be removed. So the incision goes much beyond the lateral canthus. So these are the different points or marking points that we put. Always you have to preserve at least 20 millimeter of the tissue from your lash to your eyebrow. That is, from the lash to the incision is 10 millimeter of the tissue. From the incision to the eyebrow, another 10 millimeter of the tissue. This is very important so that you don't end up with a lid retraction. So this is one of the patients. So this is really a very hooded lid, and this is how we do a very extended blepharoplasty. Sometimes what we do, you not only do a very extended blepharoplasty, you need to remove the fat along with it. Because of the gravity, the whole of the periorbital fat, especially the roof, has been descended. Here not only the skin orbicularis that I am removing, see there's so much amount of tissue you need to remove. As you can see here, I am also doing an extended blepharoplasty, trying to remove the pre-eponeurotic fat, both the medial and the central. And this is an orbital septum. I'm just cutting it away because sometimes it might lead to adhesion and might give a lid retraction. And here this is the central fat pad that is being exposed, that you can see. So a very extensive surgery, this is being done, and then you have to cauterize it very well because she is very elderly. She'll have lots of systemic issues like diabetes, hypertension. So the amount of tissue that has been removed, the skin, orbicularis, part of the orbital septum, then the part of the lateral fat pad, and the part of the central fat pad, and the part of the medial fat pad. I think I have also removed some of the roof, and this is very routinely I do for many of the patients for the hooded lid. So there's so much of fat, this because of gravity, everything has descended so much, so you need to remove some amount of the your roof, that is a retroorbicularis oculi fat. And then this is the same way you're doing an internal bropexy. You approximately 10 millimeter from the orbital margin, you mark it, pass the suture to the periosteum, and then to try to fix the soft tissue. That is tissue just approximately 10 millimeter above to your orbital rim, you fix it to the periosteum, and then you can also go for a direct brassiere suture. Brassiere suture means you need to lift it, you pass the suture from the orbicularis to the arcus marginalis, then to the superior orbicularis in the form of a matrix. So it really gives a very beautiful lift, the lateral lift. You can see here on the table, you can see the lateral lift, and this is very common in Northeast India. Like we get a very heavy lids in the Northeast India, and it really gives a very beautiful correction. So this is just, you can see so much of tissue has been removed, and you can see how beautiful it looks. So the extended blepharoplasty, I mean to say that the for patient hearing.
Thank you so much, ma'am. And indeed, it's not just the upper eyelid, we need to tackle the eyebrow as well. And you must know all the non-surgical as well as surgical procedures. Like ma'am beautifully described the filler with the cannula, it's quite safe, even though fillers, vascular aspiration has to be checked. But if you're doing it with a cannula in the eyebrow region, you can give a real on table the appearance changes in front, and especially one side you do and the other side is not done, you can show the patient how much improvement you have achieved with a non-surgical method. Surgery remains the gold standard, but aging is still inevitable. These patients after surgery also may eventually need some titration a decade down the line. Always counsel the patients regarding that previously. Now we'll have Dr. Sonali, and she'll be talking about the upper eyelid blepharoplasty, especially the skin marking and the step-by-step approach.
Good afternoon, everyone. I'll be speaking about the upper lid blepharoplasty. So dermatochalasis is a common age-related involutional change which is associated with a upper lid where there is excessive redundant skin folds and there is fat prolapse through the orbital septum. So steatoblepharon basically is the prominence of the eyelid fat pads and applies to the upper and the lower eyelids both. It may be associated with the weakening of the orbital septum and the overlying orbicularis muscle and skin. So this is how dermatochalasis presents with redundant skin without any fat prolapse in the upper two pictures, and this is noticed more in the down gaze, while some presents with both upper and lower eyelid fat prolapse along with the redundant skin. Excessive medial bulge results in the medial fat pad which does not directly lie over the aponeurosis and it's partially covered by the orbital septum, hence it cannot be retracted back completely by the contraction of the septum. Now, there's also preseptal orbicularis fat which can be contributed to the upper lid fullness, as you can see in the picture. Any lateral upper eyelid bulge should also be noted as it may be a prolapsed lacrimal gland, as you can see here. Understanding these anatomical details allows one to examine the various bulges on the upper eyelid accurately. So now the topography and the senile changes of the eyelid. In the young age, the brow position rests at or above the superior orbital rim. The lid brow junction shows a convexity, and ideally the ratio of the tarsal platform to the distance between the upper lid crease and the brow should be 1.16, which is the golden ratio. And the upper lid covers the upper limbus approximately 2 mm below in the primary gaze. In the old age, what we see is the upper periorbita, it demonstrates browtosis. The brow position is below the superior orbital rim with sunken superior sulcus, and multiple folds and blepharotosis may also be accompanied. The lower eyelid shows bulging periorbital fat and prominent tear trough deformity. So the assessment of the senile changes and the periorbital structures will allow the surgeon to determine the need to reposition the brow tail, or if a direct lid surgery alone can address such temporal hooding. Now as you can see here, there's temporal hooding, which is a common finding in elderly population. It is a combination of the temporal browtosis and the lateral dermatochalasis. The degree of the dermatochalasis can be more pronounced in certain diseases like thyroid following trauma, Ehlers-Danlos loss, blepharochalasis, xanthelasma and angioneurotic edema. Now the question arises is, do all the cases of these need to be treated? What are the indications of the surgical management? And what are the different options that are available? Now for temporal hooding, there is excess laxity with temporal hooding which can interfere with the superior and the superior temporal vision, which may make the patient constantly raise the brows or the chin in order to see. Now these patients, they usually complain of difficulty in driving and also some difficulty in seeing the traffic lights. Now the visual field that was recorded from the right eye of this picture of this patient is showing a superior scotoma, superior arcuate scotoma, which is most likely because of the superior lid drooping. Now the other ones will be your dermatochalasis with different types of upper eyelid bulges. As you can see, this male patient has ptosis. So here is a video showing to upper lid blepharoplasty along with a mulomuscle resection correction that was done for this patient. As you can see, we're making the marking and then we'll be injecting local anesthesia.
The Muller's muscle actually lies just beneath the conjunctiva.
Yeah,
so the marking has to be done before you give the anesthesia, and then after that you inject the anesthesia and apply the clamp.
Yeah. So as you can see, we've applied the clamp and now we're taking the sutures below it. I'm sorry, I'm unable to fast forward it. So I'll just describe it as it's going along. As you can see, we're taking the sutures just below the clamp. It's extremely important we take it just below the clamp so as to avoid excessive resection. And then we'll be taking an entire full thickness incision and cutting the whole of the mular muscle complex with the conjunctiva. So the dermatochalasis with different upper eyelid bulges also includes a lacrimal gland prolapse, which we can see in this very young patient, which causes lateral hooding and also brow ptosis. Now in this video we see an incision is made and we'll be going ahead with the lacrimal gland repositioning. Okay. So as you can see in this picture, there is a pre-operative picture with the lateral hooding and the lacrimal gland prolapse, and the post-operative picture is very evident of the lacrimal gland repositioning that we've gone ahead with. So another indication will be your downgaze ptosis, which is a droop of the upper eyelid that occurs because of the redundant upper eyelid skin and interferes with reading. In this elderly gentleman, as you can see here. Another indication for a blepharoplasty will be your lash ptosis. Now the lash ptosis, they commonly cause ocular irritation and entropion because of the dermatochalasis. So the constant skin to skin irritation, it may also cause dermatitis. It is a very common finding in the Northeast Asian population, which shows that there is a corneal irritation and staining. So because of the constant irritation of the conjunctiva and the cornea, there is reduced tear clearance, ocular irritation with increased cytokines and increased inflammation. So this we've covered in a paper that is written by Dr. Kasturi ma'am with long-term changes in contrast sensitivity and corneal topography and higher order abrasions after an upper lid blepharoplasty. So this shows that there are changes in contrast sensitivity after an upper eyelid blepharoplasty. As you can see here, this patient presents with a lash ptosis, and post-operatively the lash ptosis is corrected, the upper eyelid contour is directed well. Similarly, another patient here with lash ptosis and an post-operative view of the up-directed eyelashes. So another change after a upper lid blepharoplasty will be your change in corneal topography. So there have been significant reports of improvement in contrast sensitivity of the patients who undergo blepharoplasty surgery for dermatochalasis. So here are these pictures, and the redundant and the skin, overhanging skin, it blocks the light that is entering the eye, which causes more diffraction. So after the surgery, this diffraction is reduced, and this helps in the patient seeing well, and there have been patient satisfaction reports of post-surgical improvement in their contrast sensitivity. So as you can see, the higher order abrasions, there is reduction, and the lash ptosis correction causes increased contrast sensitivity, improving the functional visual acuity. So reduction in that increases the point spread function and more vivid retinal images, and this leads to a better visual acuity. So the technique will be your there are 3 types of skin marking incisions that that madam has shown previously: the classic Rees incision, scalpel shaped incision, and the Bell-in-Vias incision. So we follow the one where there is the most important aspects marking in the upper lid will be your skin excision and the skin crease marking. So one should take enough amount of time to mark the symmetry, as this is going to be the concern for the most of the patients. So as you can see in the pictures, the point A is marked 10 mm above the central lid margin. B is marked at a 6 mm from the above the medial canthus. C is marked at the lowest point of the lateral hooding, and the patient is asked to look up, and the point where the eyelid margin is in opposition to the thick upper eyelid skin, which is approximately 2.5 mm above this, a point D is marked. Now this signifies the vertical height of the skin marking. So another point E is marked 8 mm above and at an angle of 15 degrees from point C. So symmetry is the key, because blepharoplasty is an extremely important surgery. It will affect the patient's confidence later on. So always stretch the skin with some degree of redundancy, but care must be taken to remove the conservative amounts of orbicularis muscle. Incision, dissection, pre-tarsal orbicularis should always be preserved, as this will affect the blinking if it is affected. And patient's age, the degree of redundancy, whether any brow lifting is being performed or not. So small incisions over the septum will allow you direct access to the preaponeurotic fat pad. For the upper lid blepharoplasty, we can always ask the patient to close their eyes and push from the lower eyelid. That way the fat can be pronounced and can prolapse once the incision is given in the septum. So the central fat pad, as you can see, is visible. There is a medial fat pad. Okay, should I continue? Yeah. So because my time is up, I will just quickly go ahead. So yeah, so basically addressing the temporal hooding, skin crease formation, filling the A-frame central eyelid deformity and internal brow lifts are important. So temporal hooding you can go ahead with, as ma'am has mentioned, extended blepharoplasty, where only for the functional ones you have to go beyond the lateral canthus and not for the cosmetic ones. And the skin crease formation, a well-defined skin crease needs to be designed, one with use buried vital sutures from the subcutaneous tissue to the aponeurosis, or from the aponeurosis to the skin closure. So I'll just skip over this. Internal brow lifts, KB ma'am has mentioned quite a lot of it. Yeah. So the art of blepharoplasty is to know how much to reduce, how much to preserve, and how much to reposition. So, thank you. I'm sorry it extended beyond the time.
Thank you, Dr. Sonali. So after your talk, everybody can start marking and doing step-by-step skin and orbicularis upper lid blepharoplasty. For the greater indications, maybe a couple of more ICs will be required. But this is something, because we are addressing, I'm sure, ptosis surgery when you're doing it, start doing the blepharoplasties in those, especially the adult patients, and you'll start getting a hang of it. We are short of time. I'll be taking some time for this talk, and then I have a 10-minute video for Dr. Debraj Shom's talk as well. So all in all, it's going to be a summary of the topics already discussed. So one point that I want to mention is that the kind of periorbital changes vary in the young population. I consider myself slightly young, so this is my photograph. You have flattening of the eyebrow, overhanging upper skin, which is minimal. Wrinkles are there. There's a palpebromalar groove, and of course skin texture changes and dark circles and bulges will be there, along with malar mounds and tear trough. Compared to this, in the older population, you're likely to have prominent fat bags, the double convex deformity, along with this dermatochalasis, horizontal laxity, which is not there in the younger population, but definitely there in almost all of the population above the age of 60, and periocular skin wrinkles. So when do you want to go for a transcutaneous approach for the lower eyelid? When you want to address this eyelid laxity in the older population. When you're already doing a combination procedure like a lateral tarsal strip or a BICS for horizontal or Jones for vertical support, or even a punctal eversion surgery where you're doing a punctoplasty and a punctal inversion, so all of these become the functional indications. So transcutaneous would be more for the functional blepharoplasty. Especially if you have any cutaneous lesion like a xanthelasma or a solar keratosis which you need to excise, you have to give a skin excision. Try and incorporate that in your horizontal tightening when you're doing the blepharoplasty. There's another almond eye surgery where you want to elevate the lateral canthus and remove only the lateral part of the lower eyelid redundant skin, called the boomerang technique. Here also transcutaneous is sometimes recommended. Of course, last is surgeon comfort. Sometimes transconjunctival can be a little challenging in the initial part, although it is a safer technique in terms of risk of complication, but it is the surgeon preference what they want to do. So the pre-surgical processes, no two eye bags are the same. We must evaluate each and every detail. Can the video be played? Okay. So besides so over here you can see the xanthelasma and the skin changes. So over here I would want to go for a transcutaneous. Don't miss out on a subtle entropion. Always check for laxity, the eyelid pinch test, and punctal eversion. Take gazes in all three, up gaze, straight and down gaze. That helps you plan better. In the up gaze, the lower eyelid fat bags become more prominent. Every patient who comes to you will be going to other places also. Always take a history. Now this lady came, then she got a filler, and now she's come back that removed the remaining fat bags. My filler has worked for a lot. So they're challenging cases. Ask them to bring old photographs. See what they realistically are expecting. See those, and also check for pre-existing asymmetry when they were younger. Counsel them about that. Skin marking always in the sitting position. Always mark the orbital rim and the excess bags that are prominent. The transcutaneous marking can also be done with a skin pinch technique when the patient is supine before giving the anesthesia. Coming to the surgical steps, I greatly refer to one Dr. Richard Allen videos.
to the Atlas by Dr. Don Kikawa. These are easily available, and you must go through these when you're planning eyelid surgeries. So the first part is the skin-only incision. This means that when the incision is made, it has to be so superficial. After passing the traction suture, using the monopolar cautery, just superficially mark the points about infraciliary region 2 mm from the eyelid margin. Just do a scratch kind of an incision so that you are lying in the subcutaneous plane and you have not disturbed the pretarsal orbicularis muscle. The dissection is carried very superficially. You can switch over to scissors if you're more comfortable, or you can continue with the monopolar cautery. Always have a suction handy because the smell of charred tissue can go to the patient if they are under local or monitor anesthesia care and can be bothersome. The superficial dissection has to be done to preserve the pretarsal orbicularis to avoid any inadvertent eyelid retraction. Coming to the step 2, we now have to enter the preseptal plane by incising the orbicularis muscle in the preseptal part, and you have to then identify the rim and do a blunt dissection of the orbitomalar ligament as beautifully demonstrated by Dr. Kasturi. Steps are now essentially similar. Now once I enter the septum, whether I've come from the conjunctiva or the cutaneous side, it is similar in nature. So this is the pretarsal, then you have the preseptal, and then you have the orbital part of the orbicularis. And your incision now will be in the preseptal part so that you have not disturbed the lower eyelid retractors or the tarsal muscle. And you can palpate the rim with a blunt instrument or even your finger if you're more comfortable. The dissection has changed to a blunt instrument and the preseptal orbicularis has now been opened up. It's a multiplanar dissection. Then tackling the fat, whether you want to excise, reposition or sculpt. So depending on the kind of region you're working, like I work in North India, too many eye bags, mostly excision is required, but some people, especially female, have a tear trough where I would like to reposit the medial fat bag. Similar to the transconjunctival, you create the pedicles and do it. Over here, the video shows the excision. Lateral fat pad is quite deep. You have to go deep inside and then press on the globe to provide traction and make the fat pad prominent. Central and medial can also be excised. And after this, you have to see the contour. The preseptal orbicularis that you had opened up should be sutured with one dissolvable suture to maintain the hemostasis and ensure that the scarring is minimal. So you can sculpt the fat, excise some and sculpt some. Then correcting the laxity. Now, when a lateral tarsal strip or a Jones plication or any other eyelid tightening procedure is planned, transcutaneous is a good approach. Over here, if you're doing a canthopexy, like the vector has been described, the negative and the positive vector, if you feel that the patient has a prominent negative vector, in this step, when you're doing the lateral tarsal strip, you can hitch the strip to a level above the pupillary center. This provides for a good contour and also eliminates the negative vector and gives a very good aesthetic outcome with a small modification in your surgical step. Laxity should be addressed only if it is required. After this, you redrape the skin, excise conservatively. At the most, you will be excising about 2 to 3 mm, more so in the lateral corner, and medially avoid any excision, otherwise you'll have a punctal eversion and the patient will come with watering and epiphora, and that will be very difficult to handle. The skin closure has to be very meticulous. You can use interrupted sutures, you can use a continuous suture. I prefer Prolene because of the limited scarring, and when we are going transcutaneous in the lower eyelid, scar has to be minimal. This is how the patient looks on table. Of course, bleeding is expected. It's a quad blepharoplasty, so the upper lid has also been done. Coming to the complications, so some of them expected are the ecchymosis, the edema, as well as the chemosis. This is the age group where you do get these things after functional surgery as well. Allergic reactions, sometimes they develop allergic edema, especially if they are allergic to sutures being used. Dry eye and blepharospasm can happen if you have not checked these preoperatively. And the most dreaded complication in the transcutaneous approach is the eyelid retraction. Mild cases may be managed conservatively. They sometimes happen due to the edema and the hematoma. But if it's severe, you need to give inverting sutures and release the retracted part from the transconjunctival route. Thank you. And now I'll take the liberty to play Dr. Debraj Shom's video. I think he's in another one of these halls somewhere, but he cannot come here. But he was kind enough to record his presentation. So his was more of a blade-free blepharoplasty, and he does talk about, can I have the volume please for this? Can I have the volume for this video?
I thank Dr. Aditi for giving me this opportunity to speak in the instruction course. There is a parallel instruction course which is running, and so it becomes difficult to be present in two places at one time, and therefore I'm making this through a recording, this presentation through a recording. I'm also grateful to all my colleagues who are on this panel, esteemed panel, and thank you once again for allowing me to be here with you all. My name is Debraj Shom, and we run a chain of clinics called the Aesthetic Clinics. We are headquartered in Mumbai, but we are in 6 cities in India as well. I'm American board certified in facial cosmetic surgery. Certain disclosures need to be in place first. I am have been a faculty with all of these companies for a prolonged period of time. And obviously, most of our results would not have been possible without the wonderful dermatology team, which is part of the aesthetic clinic. The eyes say it all. When we look at this celebrity, superstar, Bollywood megastar, we realize that the eyes say it all. When you look at his earlier pictures and you look at his current pictures, it's obvious that while the rest of the face has remained almost similar to before, it's the under eye areas which have started to age significantly. And there's a reason for that. The under eye areas have the thinnest skin of the human body, and this is also the part which moves a lot, blinking up to almost 15 times a minute, leading to this side or this part of the face aging quicker than other parts of the face. We all know that when we look at a youthful woman, especially a woman, but you see it in men as well, you see an OG curve, which is essentially a concavity in the under eye area, followed by the malar convexity, followed by another concavity, and then the mandibular convexity. This S-shaped curve is a sign of youth, and maintaining it is what we try to do with and without surgery. If you look carefully at this particular model, it's clear that she's very beautiful, but you've been paying so much attention to the symmetry of her eyes and the brow area, which are almost like mirror images of each other, that you've ignored her lips. If you look carefully now at the lower part of the face, you see that the lips have been badly done with fillers, and it is very asymmetrical between the right and the left sides. The reason you didn't mention it or you didn't notice it is because socially we've been primed to look into the eyes while talking, which is what you were doing, and therefore you almost missed the asymmetry of the lids. So as oculofacial plastic surgeons and as ophthalmologists, we are in a position of strength because we have treated the eyes before. And this is the most important part, or in some sense, the jewel of the face. If we think of facial aging, it's very simple. It's Mother Gravity being ever so kind and pulling all our facial tissues downwards and medially. And as the facial tissues get pulled downwards and medially, we have the under eye hollows developing, and also the nasolabial folds, the melomental lines, and the jowl laxity occurring. So in some sense, it is the same sort of aging process which causes the under eye hollows, causes the under eye bags as we age, and also causes the laugh lines. And therefore, an aggregated way of treating this would be to move all the facial tissues upwards and laterally. You can't just treat the under eye area in isolation. It needs to be looked at holistically with the rest of the face. We've already spoken about this, and if you think of it, plastic surgeons believe that blepharoplasty is the panacea for all under eye treatments. Dermatologists tend to believe that fillers will solve all. The actual truth is that diagnosis and treatment requires a systematic diagnostic approach and individualized treatment. Now, if you see this particular patient, you'd probably say surgery and say blepharoplasty would be the way forwards. Yes, we would mostly do blepharoplasty, transconjunctival under eye blepharoplasty, possibly with some carbon dioxide laser resurfacing for tightening the skin on the skin side. However, what you need to understand is the quality of the skin cannot be improved with surgery alone. And therefore, most of these procedures will need a combined therapy or holistic approach as is being described. Now, we divide the under eye into various parts. We have morphological names for it, naming it as troughs, tunnels, valleys, and mountains, because that allows people to really understand what needs to happen in different parts of the eyes. And the tear trough deformity is the most important. Then we'll talk about the hypertrophic orbicularis oculi muscle or the tunnels, the problems created by the fat bags and which are the mountains, and then the valleys which are also there on the face. So topographically describe the face and describe what we do as treatments for different parts of the face. So this is a paper of ours which has been published in Journal of Cosmetic Dermatology. Even when we use the fillers, we use it laterally, and by using it laterally, supraperiosteally, below the orbicularis oculi, we can have high chi prime fillers which tend to last even 18 to 24 months being used, and the risks of bruising, etc., decrease significantly. In this, what we do is, instead of injecting medially, as you can see the tear trough, we inject laterally and handle the volume deficit on the lateral side, leading to the orbicularis oculi becoming tighter, causing a hammock-like effect, and that causes the medial side to look better. And this, we have found, gives us very good results where the patient can go to work the very next day without the worry of any bruising, etc., which might occur in the medial parts. This patient is a 28-year-old model coordinator. She came into us. She has volume deficit, as you can see. And using the technique that we've described, you can see how the lid cheek junction has become shorter, eyes appear much more rejuvenated, and she obviously appears much more fresher, younger, and rejuvenated. Similar for another, this 29-year-old lady who has tear trough deformities, and we've treated with fillers. Again, the lid cheek junction becomes shorter immediately, and you can see how the eyes look much more elegant, look much more rested and rejuvenated. Some people have these sort of problems when they are smiling. They have these hypertrophic orbicularis oculi, and that in turn means that when they are smiling, the eyes almost completely disappear because of the eyelid roll. And so from that perspective, using botulinum toxin in the midpupillary line causes these eyes to open up beautifully, allowing the eyes to be visible. This is also used for flattening the rolls below the eyes and making the eyes more visible and larger, which in turn adds to the aesthetics of the entire look. This is a photograph which has been taken courtesy of Dr. Milind Naik. Some patients have asymmetry in the eyes, further accentuated between the right and the left sides when the patient is trying to smile. And in this particular patient, while she had been advised blepharoplasty surgery by multiple colleagues, we decided to do a little bit of botulinum toxin, like I've described for the hypertrophic orbicularis oculi, and fillers in the tear trough area, which in turn cause the eyes to open up and look much more rejuvenated and symmetrical even when she's smiling. And she's very happy. Fillers will last for 2 years or so. The Botox can be repeated every couple of months. You've avoided a surgery, and the cost is far lesser than blepharoplasty surgery. Some patients will have these eyelid bags. She's a 33-year-old. She didn't want surgery. Either you can remove the mountain by doing a blepharoplasty surgery, or you can rejuvenate it by doing fillers in the lateral and the inferolateral area, as we've described. In fact, in the post picture, you can even see the injection marks. And once you've done that, you can camouflage the eyelid bags. You don't need to remove it, and fillers can do a good job, especially in such asymmetrical cases or in young patients who don't want surgery. This is the patient immediately after a week or so, and you can see how she looks rested and completely symmetrical. Facial thread lifts are something that we do regularly. Facial thread lifts are important in raising the face, and when you raise the face with these thread lifts, you can actually go ahead and lift the facial tissues, thereby leading to upward and lateral displacement of the facial tissues, as we've described on an anti-aging procedure. We also use a lot of lasers around the eyes. Our two workhorse lasers are the Q-switched Nd:YAG laser, which is utilized for removing dark circles, and the fractional CO2 laser, which we use post a blepharoplasty for skin tightening as well as rejuvenation. These are some patients with peels, etc., and Q-switched Nd:YAG laser, which makes the under eye look more rejuvenated. Some patients with CO2 laser as well as fillers, which have avoided the surgery and therefore is blade-free. And some other patients who had multiple combination treatments, including CO2 laser, to make the under eyes look, skin look less crepey, more rejuvenated, and better looking. This is a patient who's undergone an upper eyelid blepharoplasty, a lower eyelid blepharoplasty, a mid-face lift, and CO2 lasers, and these are some of the results which can be created post-surgery as well. All in all, there are a number of techniques which can be done, and we should have different tools in our armamentarium. We should have different tools available to us. This is something which will make all our surgeries look better. This is something which will make patients happier. All in all, beautiful eyes is what gives rise to a beautiful face. by making sure that we have different blade, non-blade and other types of eyelid rejuvenation procedures in our armamentarium, we can make sure that our patients are very happy, and there are various tools which are available for various people to look rejuvenated. I thank you once again for your kind attention and a patient hearing.
So I saw quite a few retina people enter for a blepharoplasty session, and that made me realize we've exceeded our time. So handing over the hall to the next session, and I hope this has been useful to all those who attended it. Thank you so much.